It is essential for the understanding of the thoracic paravertebral block to study the appropriate anatomy. The indications for thoracic paravertebral block for orthopedic surgery are relatively few, but would include multiple rib fractures and flail chest. Other non-orthopedic indications would be unilateral mastectomy and unilateral thoracotomy. The obvious three major problems with this block are intrapleural catheter placement with or without pneumothorax formation, epidural, and subarachnoid injection. As is the case with all paravertebral blocks, two very important principles apply with this block. A, because the nerve roots are covered with dura, sharp and/or thin needles should not be used for thoracic paravertebral or any other paravertebral block. Even a 22-gauge B-bevel needle or 22-gauge TUI needle are not advisable due to the danger of dura or pleura penetration and large volume subarachnoid injection. As a general principle, large bore TUI needles, 16 to 18 gauge, should be the best choice to use. These needles are the least likely to penetrate the dura or the pleura. B. The indication for this block should be very carefully selected and weighed against the possibility of doing a thoracic epidural block. The principle of the lower the indications, the higher the complications, and vice versa applies here. In the opinion of this author, breast reduction surgery or mastectomy are soft indications for this relatively high-risk block, and the risk-benefit ratio of this block should be carefully evaluated and applied. It should also be remembered that the breast gets richly innervated anteriorly from the contralateral side, and unilateral paravertebral block alone is usually not sufficient for unilateral breast surgery. Almost all local anesthetic agents known in various concentrations, volumes, and combinations have been used successfully for this block. This author's choice is to use 20 to 40 milliliters ropivacaine, 0.5 to 0.75%, or 20 to 40 milliliters bupivacaine, 0.5%, as an initial bolus. Only one level block is probably necessary if the catheter is placed correctly. This is followed by a continuous infusion of 3 to 10 milliliters per hour of ropivacaine, 0.2%, and patient-controlled regional anesthesia boluses of 5 to 10 milliliters of ropivacaine, 0.2%. In this thoracic paravertebral catheter placed in a pig, it can be seen that after 1 milliliter of India ink injection, spread is mainly localized. After 12 milliliters India ink injection, however, it can clearly be seen that the spread is largely local, but it also spreads cephalad and caudate. If the pleura is injured, as in the case with rib fractures, spread will also be intrapleural. Palpate and mark the dorsal spine of the thoracic vertebrae, which is opposite to the most appropriate thoracic dermatome for the planned surgery. Mark a point approximately 3 to 4 centimeters directly lateral of the midpoint of this spinous process. After disinfecting the skin with an appropriate antiseptic solution, cover the area with a sterile fenestrated transparent plastic drape. The skin and subcutaneous tissue are anesthetized with a fine needle and lidocaine and epinephrine 1 in 200,000 solution. Note the slight mesiad tendency of the needle. Note that contact with the bony pars intervertebralis or articular column or transverse process of the particular vertebra is sought before the local anesthetic agent is injected. Also note that a longer needle may be used for proper subcutaneous anesthesia, as in this demonstration. Injection of local anesthetic agent is only after bony contact has been established. This is extremely important to minimize the theoretical but dangerous possibility of intracord injection of local anesthetic agent. The intended path for tunneling the catheter is also anesthetized. The nerve stimulator, set to a current output of 1 to 1.5 milliamps, a pulse width of 200 to 300 microseconds, and a frequency of 2 Hz, is attached to an insulated 17 or 18 gauge TUI needle. The needle is, after entering the skin, advanced in a slightly mesiad direction until contact with the bony pars intervertebralis, articular column, or transverse process of the particular thoracic vertebra is established. The stylet of the needle is removed and a loss of resistance to air syringe is attached to the needle. After contact with the bone, the needle tip is walked off in an inferolateral direction as indicated here. As the needle is advanced for approximately 1 centimeter after walking it off the bone, a clear loss of resistance to air is encountered, at exactly the same instance as intercostal muscle twitches appear. It is important not to inject local anesthetic agent or normal saline through the needle if placement of a stimulating catheter is planned. If this is not planned and a single injection block is all that is required, local anesthetic agent can now be injected through the needle. Approximately 1 to 2 milliliters can be injected for every segment that needs to be blocked. Although the standard technique is to block every segment separately, if the needle is correctly and accurately placed with loss of resistance to air and a nerve stimulator, this is probably not necessary. The nerve stimulator is removed from the needle and attached to the proximal end of the stimulating catheter, the catheter tip placed in the needle shaft. Notice the broad black mark on the catheter, which indicates that the tip of the catheter is situated at the tip of the needle. The needle is advanced beyond the tip of the catheter, and the motor response should remain unchanged during catheter advancement. If the motor response, however, changes or the twitches stop, carefully withdraw the catheter tip to inside the needle shaft again, make a slight adjustment to the needle such as turning it 1/4 turn clockwise or counterclockwise, or advancing or withdrawing it slightly, and advance the catheter again. Repeat this maneuver until brisk intercostal motor twitches are observed during catheter advancement. The needle should not be manipulated if the broad black mark is not totally visible, which indicates that the catheter is fully inside the needle shaft. Again, observe the intercostal motor response during advancement of the catheter. The needle is now removed without disturbing the catheter. It is probably not necessary to tunnel thoracic perivertebral catheters, but if this is required, a dedicated tunneling instrument can be used, or, as in this illustration, the stylet of the needle can be inserted 1 to 2 millimeters from the catheter exit site to the previously marked and anesthetized spot. Railroad the needle back over the stylet and feed the catheter retrogradely through the needle. Remove the needle and use the silicone tubing that protected the catheter tip while packaged, which is handy to now protect the skin beneath the skin bridge. Clip the snap lock device to the catheter and the nerve stimulator to the snap lock. The brisk intercostal muscle twitches will disappear immediately upon injection of local anesthetic agent, which is a positive Raj test and which gives final assurance that the catheter is not intrapleural and that primary and secondary blocks will be successful. The catheter and snap lock is attached to the stat lock, which is applied to a convenient position, and the catheter exit wounds are covered with a transparent dressing to facilitate daily inspection of the sites.